Okay, ladies and gentlemen, I welcome you to the last webinar of the vascular section of the EANS. Again, we have a very interesting topic. We are talking about bypass surgery. We have a well-renowned expert in this field. It's Professor Luca Regli from Zurich, Switzerland. And he works at this place where I would say the bypass surgery was more or less invented. So he's a successor of great neurosurgeons who worked already in Zurich. Luca, I'm quite happy that you're here with us, that you can give your talk. The talk is about 45 minutes. And if you have any questions, please put it in the F and A section. And at the end of the talk, we try to answer all the questions which we'll raise during the talk. Luca, the stage is yours.
Okay. Well, thank you. Thank you, Veit. Thank you, the ENS. Thank you to be actually all of the participants. I see that the participants are rising already in number. So it's great. So I will start right away. Veit, we discussed about the topic, and bypass I think is interesting because there's always the question, I mean, is there still a role for bypass today? So I kind of gonna share my screen and not forget to share my screen. There we go. Let me just there, and just give me a little sign when the screen.
Perfect.
Excellent. So that's why I decided with you, Veit, to do about bypass, and I called it Bypass Surgery 50 plus years, revisiting the role of bypass surgery today. I think there's a great role for bypass surgery. So let's go. Maybe the first thing I want to say, not only everything I'm going to be saying, but today to be a modern vascular department, it's really a teamwork. And for example, in Zurich, we have 5 senior staffs, junior and senior staffs who really do neurosurgical vascular. And each of them has a specific role also, like Giuseppe is more for revascularization, Menno more for like AVMs and bleeding, Tristan, it's digital vascular neurosurgery, Jorn is doing the advanced neuroimaging, and Michael Hugelshofer, for example, is the specialist in doing research for hemoglobin toxicity. So I think it's very important to understand that everything that I'm going to be saying, obviously it's not a one-man show, but it's a team effort. So the other thing, you know, you will find a lot of the part that is ischemia, you will find in the Journal of Neurosurgical Science. We did like a topic review this year, which we published with fantastic co-authors. I mean, there's Vaikosi, there is Fadi Charbel, there is Fujimura, Mayo Clinic. So if you want to read more specifically some of the topics for ischemia, you will find them in this topic review. So today we will shortly go over the history. I cannot speak from Zurich without talking a little bit of the history. I will very shortly touch on flow preservation, but mainly focus, like Veit, you asked me to, on flow augmentation. I think it's important to touch on advanced neuroimaging and then some future developments in flow augmentation. So let's look at the history. Well, the history is really, it's about 50 years ago, Yazar Gil in 67 did the first bypass on a Marfan syndrome patient. There is no documentation of it, but interesting enough, there is some documentation of the second patient. And just so to realize, already in 72, the first Moyamoya bypass patient was also treated. Now, again, 1967 was the first time this was performed for an adult patient in a Marfan patient. But the second patient it was a patient with bilateral carotid occlusion and one vertebral occlusion and recurrent TIAs every time he turned the head. And actually, if I show this picture, is because I could very well use this surgical picture today in what we do, because it's exactly the same anastomosis we do today. And if you can look also 1 year post-operative angiogram, except that left and right was inverted that time, I mean, he had a fantastic filling of the territory through the bypass. So this was also the opportunity for us last year in January, one of the last big congresses we were able to do in Presencia. We did like an anniversary symposium for the 50 years of the bypass. I think it's really such a fantastic technique that it would have been a pity not to make this commemoratory event. And Professor Yazagil, actually, I'm just going to go back, he was in video conferencing to do a presentation also there. So let's go to flow preservation and flow augmentation. And really, it's Fadi Charbel in Chicago who distinguished the two terms. And I think it's extremely important to understand when we talk about bypasses, am I doing it to preserve the flow, the bypass, or am I doing it because the patient is missing flow and I need to augment the flow? So very shortly, I'm going to touch on flow preservation. And there, one can say that if we look at the evidences, I mean, this was a paper we did in 2016, trying to look at the evidences for bypasses. And if we look at flow preservation, you see that complex aneurysm, yes, we do it, and it's a very good indication, although the level of evidence and the grade of recommendation is extremely low because there is no way one can ever do a randomized trial on bypass about aneurysms. But we do it because it really works. And there, I'm not going to show you cases. I could show you a lot of giant aneurysms. Essentially, to remember when we are talking about the flow preservation, it's that it needs a variety of constructs. It needs whatever the aneurysm, whatever the patient needs. It can be a single, a double, it can be an interposition graft, it can be a side to side. So you will have to do the bypass technique, which needs to revascularize the vessel that we sacrifice. So this will be all I'm going to say about preservation, because then we're going to go over to the flow augmentation, which is a very interesting topic as well. And in the contrary to the flow preservation, there really is a standard surgical technique there. Now, one could think that flow augmentation bypass is disappearing, but we looked actually, and we just published this this year at the literature. If you look at the publications about about bypass first, you see that it's rising. Although you see the two humps here, this was going down after the first bypass study, then there has been the second hump, but now it's still rising. And if we look at what is flow augmentation and what is flow preservation, you see that the red, the majority of publications is about flow augmentation. And if we separate that a little bit more, you will see that half of the publications are for Moyamoya, and this is really what is growing. So yes, Moyamoya, and the second indication for flow augmentation is steno-occlusive disease. Now, going very shortly about the surgical technique, we saw that in preservation there was a multitude of types of constructs of microanastomosis. For the flow augmentation, there really is one, and it's the same that I showed you from 1967, the second bypass intraoperative surgical photographs of Professor Yazargil doing an STA-MCA bypass. This is the standard technique for flow augmentation. There is obviously for Moyamoya, especially in kids, also many different indirect techniques, but we're not going to talk about those today. And I must say that a surgical technique is today the same as 50 years ago. It's not disappointing at all. I think it's more like kind of magic, and it's wonderful. It just shows again how good this technique is. And you can see that you can do it very minimal craniotomy. You don't need to do large openings, and it's just a beautiful technique. Again, STA, MCA bypass, it's on the surface, very well tolerated temporary occlusion by the collateral flow when it's cortical, and it's a very safe bypass with extremely high rates of permeability probably above a 95, even a 98% permeability. So if there has been no change in the technique, why do we think it's evolving? And that really comes from the advanced neuroimaging. It's not only the advanced neuroimaging, but what really has changed is our understanding of the hemodynamic and of which patients really need a bypass. I think there has been an immense progress there to even better use this fantastic microsurgical technique. So I will talk about two techniques we use in Zurich that we consider to be advanced neurovascular imaging. One is the NOVA. The NOVA has been developed by Fadi Charbel and also Amin Hanjani, CEPI in Chicago. It stands for Non-Invasive Optimal Vessel Analysis. It's an MR technique that allows us to measure in a quantitative way the volume flow rate using standard MR protocols. And what we get is actually flow quantitative milliliters per minute in the vessels and the direction. So which vessels can be analyzed? Well, there is one limitation. It cannot be too small. So it's about, I would say, 1 millimeter must be the diameter of the vessel to be able to accurately measure it. And then we get this kind of report. It's a schematic report of the flow quantitative, and it's quantitative, so it can be compared 6 months later. It can be compared 2 days post-op and pre-op. So it's extremely helpful to do this. And it's standard MR technique. We also have, thanks to, again, the group of Fadi, we have some references, age-adjusted references. It's also very interesting to think about flow in the vessels. So, for example, an MCA has about 120. I mean, there is a range, obviously, but maybe around 120. A PCA is around 80, and so on and so forth. So there are references. And what we get, so with the NOVA, is cerebral blood flow in the vessels. So it's not parenchyma, it's milliliter per minute. It's a standard MR protocol, and you just do a TOF, and then there's several steps. From a TOF, you send it back, you analyze, you choose the vessels you do a phase contrast, and then it goes back to the NOVA software. It is analyzed, and you get the flow. We developed several flow protocols, and it's important to realize that about every vessel you acquire needs 45 seconds scanning, extra scanning time. So you cannot just say, oh, let's do all the vessels. So you have to think about it, and this is just to get an idea. We have an acute stroke prospective research protocol, so we even do it in acute stroke. But there we keep it to a minimum. So we do, for example, A2s, bilateral, M1, and PCA. If we do more for chronic ischemia, we want to know the carotids, and then the PCA, vertebrobasilar, and the MCA and the ACA. For bypass, after a bypass, obviously we also integrate the bypass, so we can also measure the flow in the bypass. And then, for example, for carotid occlusive disease, we are more interested in the extracranial vessels. And obviously, there is also for the posterior circulation, and there is a very well-defined Veritas protocol with a randomized study that allows to show that it is highly prognostic in a risk of recurrent stroke. So extremely useful in helping us understand better and selecting the patient. Now, the second method we really helped develop here, thanks to Jorn Fierstra and his group, is the BOLD in ischemic stroke. We use it for vertebrobasilar, again, extracranial carotid disease, steno-occlusive disease, and also there for acute stroke. So what is the technique of the BOLD? It's really the blood oxygen level dependent fMRI sequence. These are the pictures one gets. Extremely a high definition resolution of topography with MR. And it's the combination. We don't use, obviously, I mean, we have to have some kind of activation of the bold signal, and we use a CO2, but not just CO2, but it's CO2 combined with a device which is called Respiract that delivers, it's a gas blender that delivers CO2 in a very controlled manner. So to remind you, once we use BOLD to measure changes in cerebrovascular reserve or changes in vessel diameters, and with that we do get cerebrovascular reserve, we do not measure blood flow. That's important to understand as a technique because the signal comes from the paramagnetic effect of the deoxyhemoglobin. But when you have a stimulus, and the stimulus is CO2, so we don't use Diamox, we don't use like the normal neuronal stimulus, we use CO2, you get vasodilation, and by that you get like almost like a functional hyperemia, and you get a washout of the deoxyhemoglobin, and thereby you get a change in BOLD signal, and this allows us to measure cerebrovascular reserve capacity. And if I go one more slide in the details, just because it's such a nice technique, you have here, for example, you can see the two curves. You see the curve of the CO2 change in the gas blender, what the patient breathes. And it's important to notice that it's almost a square immediate change from normal CO2 to hyper CO2, and very controlled. By the way, the O2 does not change, it stays stable. And you see the BOLD signal follows extremely tight to the CO2 curve. So this gas blender and this very precise change and almost immediate square changes of the CO2 allow at the end to activate and to measure changes in the BOLD signal, which actually reflect, and these are the studies we have been trying to correlate with the cerebrovascular reserve capacity, which is an extremely important measure and very difficult bedside or clinical measure to get, because PET is not so easy to get in acute and very sick patients. And xenon, for example, xenon CT is not available anymore. One of the very nice, I think, landmark studies in this domain has been this paper from Jorn and from us in stroke, where there was the comparison between PET, water PET, cerebrovascular reserve capacity with the BOLD CVR, and show one image of this. You see here the gold standard PET in the MCA territory, which the patients were according to the standard criteria of hemodynamic stages, so hemodynamic capacity and failure. So normal hemodynamic, failure stage 1 and failure stage 2, and the patients were then compared with the CVR obtained with BOLD, and you see a very good discrimination of the three stages. So this paper allowed to show that there was a non-inferiority of the BOLD CVR compared to the PET. And if we look at the specificity and sensitivity, actually the curve of or the area under the curve of the BOLD was even slightly better than the PET. So this is not just theoretical. This is extremely important when we talk about ischemia in patients, and to be able to measure it in clinical environment, not just in research, but acute patients, patients of this ICU, patients even with acute stroke. And that is what has changed in this last years, that we are much better able to understand the hemodynamic and to understand which patients are threatened in the future with a recurrent stroke or first stroke. Unfortunately, very often it's a recurrent stroke. So let me finish with the chapter Future Developments in Flow Augmentation. And we're going to take again this chart with the evidences for flow augmentation. It's obviously distributed in Moya and steno-occlusive atherosclerotic disease. And let's start with the Moyamoya. Moyamoya can be separated in two big categories. It's the hemorrhagic and the ischemic. And if we see the hemorrhagic one, is yes, there is an indication, clear indication for bypassing patients with Moyamoya hemorrhagic. And there is very strong evidence, very strong grade of recommendations because we even have a trial. There is the JAM trial, so the Japanese adult Moyamoya trial for hemorrhagic presentation. And there you see in the first analysis of the trial that the patients that were not operated and the patients the patients that were not operated had a clearly worse prognosis with 8.2% recurrence for primary endpoint, which was both bleeding and stroke and bad outcome compared to the patients who were operated. And once the data were even more precisely analyzed, it could even be more precisely indicated that in a second paper in the pre-specified analysis of the JAM trial, they looked at was the hemorrhage in the anterior region, which was defined by, you can see here in the scheme, in this schematic representation, this was the anterior region, and this was the posterior region. And even more so, if you separate the hemorrhage into posterior and anterior, the patients who present with Moyamoya and a bleeding in the posterior region have a very strong, very high risk, HR, of having a recurrence. So there is clear indication that for hemorrhagic Moyamoya, especially in the posterior type, the patient should be bypassed. And this was a recent young patient. This was a 35-year-old female, bypassed actually a month ago. She presented in July of this year with this hemorrhage, so clear hemorrhage on the CT. And if you look at the CT angio, you can already see that something is special and not normal here at the MCA. So this is also the typical image of actually Moyamoya. So this patient had a Moyamoya young patient presenting with a posterior type hemorrhage, and you have here the angiogram with a typical stenosis at the base of the M1, A1 also. You see that the A1 also has very bad collaterals to the ACA. You have the typical Moyamoya vessels. Once you inject the other side, you see some PL collateral flow to the left ACA and MCA territory. And when we do the posterior, you also see there the collaterals going over the PL network, which probably explains also through the choroidal collaterals that these vessels then bleed. There was also a tiny, you probably can hardly see it on this online presentation, but there was a tiny microaneurysm on these collaterals, which most certainly was the origin of this bleeding. She had a very good STA, and we did our advanced imaging, as we always do. And you can see, actually, you have to realize that essentially everything that is blue is already in stage 2. So it's not only exhausted cerebrovascular reserve capacity, but it is actually a steal, getting to the steal. So she had this severe CVR changes. The bold, this is important. This was pre-bypass. What can also be measured it doesn't help, but we did it. And then we don't have the bold yet because it's so recent. We just did it like hardly a month ago. But we have the post-operative NOVA because we do that the first day or second day. And you see that the bypass had 44. It's not a huge bypass flow, but still it's clearly a cerebral flow. And this is clearly present. And we will get a bold 4 months post-op. Now, so that was for the Moyamoya, typically hemorrhagic, very clear indication with strong recommendations and level of evidence. For the ischemic, we do not have randomized trials because there is such a clear indication to do it because the natural history of ischemic patients presenting with ischemia in Moyamoya is not a good natural history. And there is no other treatment, so this would be a typical case. I'm just showing this one case. Again, the typical Moyamoya occlusion at the base of the carotid. And again, the CVR bold with bilateral, and not surprisingly, this patient had also bilateral, typical Moyamoya disease, bilateral stage 2, so steal phenomenon in her hemodynamic reserve capacity. She was symptomatic on the left side. That's why we started, and then the NOVA. You also here see, which makes sense, very low flows in the MCA trunk, actually pretty high. And let me maybe just shortly come back. Now, this patient still had A1s that were open. So not surprisingly, in the NOVA, we can see pretty high flows in the A2s, probably compensating already a little bit the MCA, and also pretty high flows in the PCAs, also compensating for the MCA occlusion. But this compensation was not enough, and that is proven by the CVR exhaustion, so the cerebrovascular reserve capacity that was not only exhausted, but even reversed. So first bypass on the left, you see that this bypass carried 68 milliliters of flow in the first days. Second bypass on the other side, we had 82 milliliters, and the new bold shows already the a very good compensation of her cerebrovascular reserve capacity. So a topic that is, I will finish with the atherosclerotic part, and there it's important to distinguish. So there is obviously not only one, but two trials for the atherosclerotic, and let's call it the second trial is the COST trial. So yes, and this is going to be semantically a little bit strange, but yes, there is no indication to bypass COS patients. Patients that correspond to COS criteria, we have evidence that we should not bypass those. So this is this line. And there is the COS, there was the first bypass studies showed the same. There still are bypass studies going on, even with indirect, and the one of China. We are waiting, hopefully end of this year, maybe end of next year, the results. And I will just show 2 slides about the COS. Also there, interesting enough, it was not worse for the patients who had bypass, but it was futile. It was not useful to do it. And very interesting, it was the perioperative period. The perioperative period was, there were too many strokes in the perioperative period, and that was enough to erase the effect of the bypass. Even though also with the PET, these patients had PET also afterwards, it worked. I mean, the bypass could improve the cerebrovascular reserve capacity, but again, it was the perioperative period where the strokes happened, even though the bypass were open, 98% of the bypasses were open. And for example, if you would erase the perioperative period, So obviously we cannot do that. Huh? But if we would just follow the patients from day 2 after surgery, there was a big difference in recurrent stroke. So 9% in the surgical bypass patients and 22%, 23% at 2 years in the non-surgical patients. So we have to do something to reduce the perioperative risks. So we didn't only learn to select well the patients that are at high risk of stroking in the future, but we also learned how to select very high risk patients for surgery. So these patients are extremely fragile. So no, those who have COS, and the COS is, let me just go back, this was actually one event. So there didn't have to be recurrent events. It was enough to have one time a stroke, maybe during the acute carotid occlusion. So these patients, if they are asymptomatic afterwards, even if they have cerebral vascular reserve deficit, they are not bypassed. So how comes we still do patients? And these is what we call them now non-COS atherosclerotic indications. And there's 3 big categories. Actually, I'm sorry, there is 3 big categories in the non-COS, and then there's the acute strokes we will finish on. So there are patients who have atherosclerotic occlusion who have multiple occlusions, so not only a carotid occlusion on one side. For example, this patient. This patient, 67-year-old male, was symptomatic with recurrent symptoms, subacute strokes, but also TIAs, and he only had one vertebral artery that was open. So 2 carotids and 1 vertebral artery were occluded. This is not a COS patient. This is a completely different category of patients. So again, not surprisingly, if we look at the NOVA, huge flow through this vertebral, almost replacing a complete flow to the brain. But if you remember the standardized flow measurements we had for NOVA, a whole brain has around 1,000, around 800 to 1,000. So even 300, 400 is a lot for a vertebral artery, but is not a lot for the brain. And then you can understand how his brain functions, how his brain gets fed, but especially important also the bold here. You see severe bilateral exhaustion, stage 2 deficit of his hemodynamic functional state. So yes, this patient can benefit. He's symptomatic, he has stage 2 failure, he has occlusion of multiple vessels, he's not a COS patient, and then we did a bypass, 150 milliliters through an STA. This is not a vein graft, this is an STA MCA bypass. And look at amazing, you do on one side the bypass, both sides improve. So we also learned, thanks to these advanced studies, how connected the 2 hemispheres are and how interdependent they are. So this is a non-COS indication for ischemia. And then there's the very impaired cerebral hemodynamics, not just impaired, but very impaired. So this patient, a 60-year-old patient, presenting from 2020 on recurrent strokes with with all symptoms. Looks pretty bad. And then we did obviously all the investigation. He continued to be symptomatic. You see that he has atherosclerotic, not Moyamoya. He has atherosclerotic bilateral MCA occlusions. And this is his study. His carotids do still deliver because, but the MCAs are extremely low. He still had some flow through the ACAs, and he has very low flow in general. And look at it's amazing. This is his bold. His bold looks like a Van Gogh, fantastic painting from Van Gogh. So if you see if you see the crows in the wheat field of Van Gogh on somebody, you have to think, or the other thing, you can hold your head and think of the scream of Edward Munch. If you have anything in the bowl that looks like one of these fantastic major paintings, this is very, very bad reserve. This patient, I mean, you saw his MR also. He has multiple strokes. The brain needs blood. It just doesn't function well when it's like this. So this patient, I bypassed him on one side to start because he was symptomatic the last time on the left side. So I did him. He also was, I think, 3 weeks ago. So I don't have the bold yet, but we already have the Nova. This was 57 in the bypass, 2 days. So we do expect him that it will mature. Interesting enough, intraoperative, we always measure the flow intraoperative with a Cerebral probe, was 60. So very good correlation in the first days. But we do hope, obviously, that it will mature. And we will bypass him also on the other side, but we don't do that in the same session. Finally, there are patients who have recurrent strokes. I mean, they continue to have recurrent strokes. This is a typical example. Patient had this. We bypass him in on the right side. He compensates and he got asymptomatic thereafter. So again, please do not bypass COS patients, but there are indications. So you don't need to bypass the patients we know that it's not helpful. We have to bypass those who really need it, and we have to learn to select those. And finally, I will finish on this fight. Don't worry, I'm almost done. Acute stroke. I think the colleagues from endovascular taught us that the concept of penumbra exists really in clinical, is clinically relevant. So we know that when there is a penumbra, if we reestablish the flow, it is better. And endovascular proved it. So we have some few patients where the stroke is not the same at the beginning as in the evolution over time. So some patients grow, the stroke grows over time. In some other patients, it's the same from the beginning to the end. So we have to learn to identify these slow growers and those that cannot be revascularized by endovascular. And they do exist. It's a niche. It's very few patients. But we reported this in 17, the first experience with 8 consecutive patients that we bypassed in an acute stroke setting. And now we do a prospective collection. It's a registry. It's not a randomized study, but it's a registry where we look at acute patients presenting with acute stroke and where we do the advanced imaging and try to select the patients based on the following last 2 slides, where we kind of developed a protocol integrating the data, the imaging we showed you. We have some clinical and classic volume criteria. We have the classic perfusion-diffusion mismatch, but then we look at the bold and we look at the NOVA. And I will show you 2 cases just to illustrate that, how it works. So this was a patient presenting with an acute carotid occlusion. This was a 79-year-old patient, yes. With the stroke, we look at the mismatch. Yes, the patient had mismatch. There was no bleeding, but he had no bold CVR compromise. And if we also look at his NOVA, we look at the MCA on the ipsilateral side, on the stroke side, and on the other side, there actually was really pretty good flow. ACA also, so everything was symmetric. So if we put it into our flow chart, although the patient had a stroke, it was not too big, there was no hemorrhage, there was a mismatch on the acute stroke. We did not have CVR compromise. We did not have an asymmetry between the 2 M1s, between stroke side and non-stroke side. We did not have an hemispheric asymmetry. So these are two indices that we measure on the NOVA. So we don't do the bypass on this patient. And obviously, I'm going to show you one case which is the opposite. And then this is the very last one. Again, occlusion of the carotid, 60-year-old patient, stroke, large mismatch. This patient had a CVR compromise. And if you compare on the NOVA, the MCA, although there is flow, it is less than half of what the opposite side has. And if we do, even the ACA has pretty low flow. So if we add ACA, MCA, and PCA, the symptomatic side had less than 70% of the asymptomatic side. So again, we fill in our flow chart. The usual, yes, he had a mismatch. He had a compromised CVR. He had a compromised index of the MCA. He had a compromised index of the hemispheric. So yes, this patient qualifies for an acute bypass. And this was the case, had a bypass. Again, very high flow in this bypass as well, 140, very good compensation. And I don't have the proof that they do better, but this is what we are trying to understand, and this is how we select them. Again, for those who are interested, there is some more details in this topic review that we did, and I'm open for questions. So thank you. I was a little bit longer, but I get
you're
carried away.
Time, so the talk is 45 minutes. So you would have 2 minutes left. I thank you very much for this very interesting talk. And I already see that there are some questions in the F&A. And so I think we just now go to the questions. So
Sure.
The first question was from Dr. Kartal. He's a great fan of your work. He's writing, and he's asking regarding Moyamoya. Are there any preferences regarding indirect methods, and on what criteria you decide?
Yes. So Moyamoya, I think if we talk about technique of revascularization in Moyamoya, we have to clearly separate the category age. So kids, very young kids, adolescents, maybe teenagers, and adults. So in the adults, obviously I do prefer, and this is not only me, but also our Asian colleagues who have an extreme large experience, they prefer direct. So STA, MCA, and you can always combine it with some kind of indirect. But in the kids, that's a big question. There is the very large experience in the French pediatric neurosurgery with burr holes, multiple burr holes. It's extremely low risk and very efficient in kids, in small kids. Otherwise, it's we also published, if you want to revascularize the frontal region, then the periost is extremely good added to the dura. So it's dura synangiosis and periost synangiosis. I avoid to put the muscle. Myosynangiosis has a lot of postoperative complications, especially in epilepsy. So that's why I try to avoid the muscle.
So to sum it up, the main criteria for you is age, concerning the method you're using.
Yeah.
Okay, I think that's a very clear answer. There is a doctor from Italy, and he is asking, can you please tell us what kind of solution mixture you use to irrigate the vessels getting anastomosed?
Oh, do you mean to irrigate during the surgery?
Yes.
That's a good question. Because I mean we're talking here about STA MCA, yeah. So it's the STA. It's all about preparing it. What I do, for example, is I do not cut the STA before I have opened the dura. So I keep the STA flowing. I prepare it obviously, but I keep it flowing until I open the dura. And then I don't use, I only use papaverine, diluted papaverine, if there is spasms visible. And all the rest of the irrigation is heparinized saline.
Okay. There are a few from the same doctor. There are a few more questions concerning the technique. Possibly we should go through them. Some pearls and pitfalls of size mismatch in donor and recipient vessels.
Yeah, usually what happens is that the recipient is smaller than the donor, and especially if you take a radial artery or a vein. It's all the tricks of fish mouthing. I mean, so well, first of all, the fish mouthing makes the donor bigger. So if your recipient is too small, that's very difficult. You only can do your arteriotomy long enough to match and avoid to fish mouth the donor vessel. Now, on the opposite, if the recipient would be big and your donor very small, then you have to fish mouth it.
To use running or interrupted sutures?
That's like a always coming question. I like interrupted, and I'm not saying that running is bad, but the smaller your vessel, the more the interrupted sutures will be precise. So for me, it's two reasons. It is the most precise suture you can position. And the second thing, I still believe that if the bypass wants to grow, if you have an interrupted suture, the bypass can grow. And so yeah, those are the two reasons.
Okay, so the last question from the doctor from Italy. Your experience in bypass surgery treating blister-like aneurysms, which is a very, very different topic, I would say, and many options exist for treating blister aneurysms.
Yeah. Well, I mean, obviously we're in the topic there of flow preservation. Essentially, what he's alluding at is, blister aneurysms, if we do it microsurgically, then you have to sacrifice the carotid. And there you have to think of restoring the flow, replacing it with a bypass. It's you will never regret to have a bypass if you sacrifice a vessel. So if I know that there is a good not a good PCOM, but if there is a good ACOM, I may think of doing a STA or even a double STA MCA. But if there is the slightest doubt that the patient has an isolated carotid territory, that means that it has bad circle of Willis, I will not take the risk to have that hemisphere live on a STA MCA. And then you have to take an interposition graft with a vein or a radial artery, and that depends from the donor of the patient.
I think this is a very difficult question because treating blister-like aneurysms, there are so many, so most of us didn't treat too many of them, and so they're quite rare. You must have in mind that you have endovascular options to treat them. So there are studies out showing that you can use some sort of stenting. You have good data that you can do surgery. So it's I think in blister-like aneurysms, we have a lot of options, and I think it's quite difficult to give a clear advice what you should do. Then there's a very a question which focus on one of your cases, the patient with the right vertebral artery patency. How long post bypass was the post-op bolt done, and how long the symptoms improved?
Yeah, I mean, those bolts, we do it usually around 4 months.
Okay.
And the symptoms improve usually very quick. So what we see in some patients is, but not in this kind of patients, but in the Moyamoya patients, we see sometimes symptoms due to hyperemia. But the ischemia symptoms, they can disappear pretty quickly. I mean, that they usually don't even present post-op.
Luca, I also have a question. So you told us a lot about the new MRI techniques. So what you should do in a hospital where those techniques are not available? How can you proceed in, let's say, getting the bypass business started if you do not have the latest technologies in MR imaging?
Yeah. Well, maybe the ideal situation, again, it's all about selecting the patients. And so if you would be not far, I mean, we can do all these examinations ambulatory. Yeah? So one would be to work up the patient with your neurologist. Obviously, you have to team up with your neurologist. And the CVR, I mean, PET is still the gold standard. So if you can have access to PET, that's fine. But then you cannot do it in acute patients. The perfusion, what you also have really to understand is that those perfusion maps that you get from the MR and the stroke protocols, that is not cerebrovascular reserve capacity. Those are those perfusion mismatches. So I don't think one should start with doing acute stroke bypass patients when you start the business. So it's those non-cause patients who have very severe compromise and ongoing symptoms, and those can be worked up also in another center, and you could team up with those.
There's a very interesting question. What is about improvement of brain vascularization by, let's say, conservative methods, alimentation improvement, training, and other methods?
Wow, yeah.
Well, he wrote it works in coronary vessels.
Yeah.
So possibly it
Yeah.
also works
No,
in
it's true.
vessels.
There is actually interesting enough that one study I mentioned about the acute stroke, it also includes the rehabilitation and the training to exactly study that, to see if we can see an improvement in patients who have aggressive rehabilitation in the perfusion. So I think we have to think about this. So we have no proof currently. So we had actually after the meeting, we also had the bypass. After the bypass meeting, we also did a symposium on hibernating brain. So I think that it's not only stroke, yes, no. There is all the thing about hypoperfusion, the brain shutting down a little bit, and the opposite. If we train it, training, obviously it's not only walking, but even sports may improve the perfusion of the brain. So there are some evidences, yes. Very important topic.
That's a very focused question. How do we can gather both software whose vendor special compatibility issues with the MRI machines?
That's a very technical question. There I can encourage to contact Jorn Fierstra, who is actually my colleague in our staff, who is doing really, he's the expert on it. So Jorn Fierstra, you can contact me and I can give you the address.
Right.
Actually,
there's a very good opportunity. There's a question, how often PAA and MCA revascularization is performed, especially in patients with recurrent multisteno-occlusive vascular disease?
So that's obviously the question of which donor vessel we choose. I think we can be extremely creative, and STA is the perfect vessel. PAA is a very good alternative when there is a dominant PAA. But essentially, it's all about in patients where the STA is already used, sacrificed through another craniotomy or for other reasons. You can take the maxillary, the internal maxillary as a donor, then you put an interposition, you can pull it over on the other side. Occipital artery, PAA, STA are the direct donors, and everything outside. I actually tried, recently I tried to take the middle meningeal. I used twice the middle meningeal, and 3 weeks ago I thought I could do it in a young patient, but at the end it closed, so I had to take the STA. So it's depending on the patient anatomy.
Okay, I have a question. Are now some clear surgical advances, some recent advances which we should know in doing bypass surgery, or if we are still following, let's say, the Yashagil school and are maintaining the well-known and let's say old techniques?
No, it's really it's one of the beauties also of this surgery. You can train it in the lab. And actually, it's not only you should train it in the lab, and you don't need to put patients at risk to experiment your technique in the patient. And there, maybe in the lab, we have really been part of the development where we try to use less and less live animals for obvious reasons, and the placenta, even the human placenta, extremely easy to obtain in a hospital, and it's a fantastic material to train. So it's all about training.
I think this is a question which from Kathal Hanan, which is going in the same direction. How does one maintain the requisite volume of surgical cases for these rare pathologies? Is there a minimum catchment population, and are national service networks required? It's more a political question, I would say.
Yeah. Well, again, the skills we can well, there are maybe two things to that. First of all, I think still today that every neurosurgical resident has, during his training, to do a microanastomosis training course. I think, again, course. I'm not saying to do it on patients, but so the technique has to be maintained because it's extremely important. That's number one. Number two, yes, I'm a big believer that reference centers and networks are important to keep not only the skill, but it's the whole knowledge. And that's what I was trying to show. We use still the same skills to do it, but our understanding has completely evolved. And it's to keep up that understanding is needs networks, and you need patience. The second thing is you really have to team up with your neurologist. If they have to trust you. Those are the ones who send the patients.
Okay, so there's a question. In patients with symptomatic steno-occlusive disease, you would expect always some reduced cerebral blood flow. What is the additional value of PET bold in symptomatic patients with hemodynamic perfusion deficits in CT perfusion studies?
Well, there are two things. Well, it's not true that every patient who has, first of all, a stroke, once you have one stroke, you don't necessarily have CVR compromise. That's number one. And even in recurrent strokes, you don't always have, or recurrent also TIAs, you don't always have CVR compromise. I mean, the best example is, for example, carotid disease. It's a thromboembolic disease, and it's not a hemodynamic disease. Well, it's probably combined, but it's mainly thromboembolic. So no, it's extremely important to prove, because the bypass is improving flow. You have to prove before you do a bypass that there is a compromised reserve capacity.
Very good. So I just checked the chat, but there are no further questions in the chat. I think we hopefully answered everything, which was interesting. Luca, I thank you very much for this very interesting talk on a on a very interesting topic, on a rare pathology. I wish you all the best for the rest of the year, and hopefully
Thank
we
you.
can meet each other again in 2022. Thank you very much.
Thank
Bye.
you, Veit. Thank you to all the participants for this interesting discussions, and wish best season greetings and Merry Christmas to all the ones. Bye bye.
Bye bye. Thank you.